Hi everyone, hope you're all doing good. In this video, we are going to discuss about breech. See, in breech presentation, you have to understand that the lie of the fetus is longitudinal. So, when longitudinal, the baby can present in two ways. Either the fetal head can be entering the pelvis first, or the fetal buttocks can be entering the pelvis first. So, when the fetal buttocks is entering the pelvic first, then it is known as breech. Okay. So, buttocks entering pelvis first. But sometimes even the lower extremity can also enter. Clear? See, if you see most of the antenatal, repeating again, see if you see most of the presentation of the baby at 28 weeks, around 25% will be having breech presentation. Then this will reduce as the gestational age is progressing because the baby can go for spontaneous rotation in utero itself. So, if you take around 32 weeks, this can be anywhere between 7% and 34 weeks, by which most of the spontaneous rotation would have been over. Okay. So, after that, the chance of getting spontaneously rotated by cephalic presentation is very less, right? So, the chance is only 5%. And at term, there is only 3 to 4% of breech presentation. Clear? So, this is very important. Understood? Right. Now, we will see another important point. Suppose if a woman has breech presentation, the recurrence of breech in her second pregnancy is having a chance of 10% and the recurrence of breech presentation in her third pregnancy will increase further and it have a risk of 27%. Clear? Right. Now, we will see what are the risk factors for breech presentation. So, risk factors or the causes. First point is Mullerian anomalies. So, these can be septate uterus, bicornuvate uterus or didelphys uterus. Then, if there is uterine leiomyomas, especially in the lower uterine segment, and if it happened to be an intramural or submucosal fibroid. Clear? The other etiology can be about the placentation. If there is placenta previa, then about the like, see both oligohydramnios and polyhydramnios are going to cause trouble because with polyhydramnios, there is an unstable lie. The baby has lot of space because of the increased leg, so it will be keep on rotating. Okay, and in oligohydramnios, it doesn't have space to turn. Clear? And then we will see what are the factors from the fetus that are causing breech presentation. They include prematurity, female gender has more breech presentation when compared to the male gender babies. Then, when there is aneuploidy, fetal neuromuscular disorders are present, or any other anomalies like sacrococcygeal teratoma or fetal goiter, etc. See, it is easy to remember these causes because if you see all these causes, like lower uterine segment fibroid or placenta previa, what is going to happen is they are going to hinder the fetal head from coming and occupying the lower uterine segment, because the fetal head is going to be bigger than the body and the breech, right? It needs more space. When there is hindrance, what happens? It tries to accommodate itself in a more convenient space, which is the fundus, right? So, the same way, if you see some of the other causes like sacrococcygeal teratoma or fetal goiter, what is going to happen is the space is more because of the enlarged thyroid or the mass present. So, the baby is not able to turn. So, it remains mostly in the breech presentation itself. Clear? Right. So, we will see the classification of breech presentation. Classification of breech presentation includes 3 types. One is frank breech. Next one is a complete breech, and the third type is incomplete breech. Okay. So, what is this frank breech? Frank breech is one where there is flexion at the hips of the fetus and extension at the knees of the fetus. And complete breech is one where both the hips and knees are flexed. Okay. And incomplete breech is one where one or both hips are extended, and here there is another special type example, namely Footling breech, where one or both feet is below the breech. Clear? So, these are the types of breech. So, you have a frank or extended breech. I already told you frank or extended breech is one where there is flexion at the hips and there is extension at the knees. Clear? So, the position will be just like this. Okay. Here in the complete or flexed breech, what is going to happen? The flexion is seen both at the level of hips as well as at the level of knees. Clear? And Footling breech is one where there is foot presentation. Clear? And there is also extension of the hips. Okay, one hip is extended here. Understood? So, these are the types of breech. And apart from these types, I want to tell about one more type of fetus that you will be able to see in ultrasonogram, that is stargazing fetus. So, what is the stargazing fetus? Okay. See, in some cases, the fetus may have an hyperextended head. Okay. So, in that case, if you are trying to do vaginal delivery, okay, it can injure the cervical spinal cord. Okay. So, this hyper extremity head. So, this type of stargazing fetus is seen in 5% of the babies, right? Now, we will see the examination part. So, what are the findings you get when you perform maneuvers? Okay, that is abdominal examination. So, per abdomen examination shows that the first maneuver, you will be able to see hard, round, regular, ballotable fetal head in the fundus, right? Then the second maneuver shows hard, broad back on one side of abdomen, whereas the other side you will have, yes, small multiple knobs on the other side, and in the third maneuver, if the fetal breech is not engaged means you will be able to see a softer, broader breech part that is movable above the pelvic inlet. Then if it is engaged means you will be able to see the breech just beneath the pubic symphysis. Okay, but sometimes there can be a confusion in this and you can even confirm it with an ultrasonogram. Clear? Right. Next, about the vaginal examination. So, we will see what we will be able to see in a frank breech. In frank breech, you will be able to palpate the ischial tuberosities. Okay, imagine the buttocks of the baby is in the lower pole, so that while doing pervaginal examination you are going to feel the buttocks of the baby. So, you will be able to palpate the ischial tuberosities, you will be able to palpate the sacrum, and you will be able to palpate the anus, right? And then if labor is prolonged, sometimes due to the compression of the breech over the pelvic bone can lead to edema. Okay. So, in that case what happens is this anal opening can be mistaken for mouth and ischial tuberosities can be mistaken for malar eminences. Okay. So, there can be a confusion in this thing. Okay. So, we are going to see the difference between these two. So, we will see the anus and the mouth. So, how we are going to differentiate it? We are going to leave one finger inside the opening whichever we are feeling, and we are going to find the difference between the anus and the mouth of the baby, right? See, anus, you will be able to feel a muscular resistance, whereas the mouth is less yielding. And in the anus, there can be meconium staining, right? Whereas in the mouth, you will be able to palpate the jaws and the palate, right? And third point is that here the anus and ischial tuberosities are going to form a straight line, okay? And in the mouth and malar eminences are going to form a triangle shape. Clear? Right. So, how do you feel a complete breech through vaginal examination? See, if you take a complete breech, feet will be felt alongside the body. Okay. So, feet felt along the body of the fetus. Okay. And then in the footling presentation, one or both feet are seen below the buttocks, right? Then, in case of assessing the fetal position, know that you have to search for the fetal sacrum because that is going to be the denominator. So, the possible positions of breech presentation include left sacro-anterior, left sacro-transverse, left sacro-posterior. The same way, right sacro-anterior, right sacro-posterior, right sacro-transverse. Clear? Right. Now, we will see the ultrasonogram findings. So, in USG, if breech persists more than 34 weeks, then you have to check the following. Okay. Then you have to know the type of breech, if there is any flexion or extension of head is there. Then just confirm the gestational age once, whether you will be able to give some time for spontaneous rotation or not. Then confirm the volume of fluid. You have to check for the placental location, and then check if any fetal or uterine anomalies are present. Clear? So, we will see the antenatal management now. So, antenatal management, we can perform a maneuver called external cephalic version. This version is a maneuver in which we are going to help the woman in turning her baby from breech presentation to cephalic presentation, thus helping her to increase her chances of having a normal delivery. Clear? So, what is version first? It is physically substituting one pole of a longitudinal presentation for another. Clear? So, you can change the oblique or transverse lie to a longitudinal presentation. Okay. So, you have two types in this. One is external cephalic version, which is shortly written as ECV. In external cephalic version, we will be performing the procedure through the abdominal wall, and you will be trying to change the breech presentation into cephalic presentation. Yes, whereas you have another procedure, namely internal podalic version. Here you are going to do the procedure through the uterine cavity, and here you are going to change it to a breech presentation. Okay, for example, a transverse lie of a second twin after the delivery of first twin. After the delivery of first twin can be done by internal podalic version, and this is the only obstetric indication of doing internal podalic version now. Okay, and here this can be changed into a breech presentation and it can be delivered. Clear? Right. Now, let's talk more about external cephalic version. First, let me show the procedure. So, this is about the external cephalic version. So, what is going to happen is, I hope if you were able to see one Rajnikant movie, that is Endiran, that the robot will be performing this procedure, right? So, this is what it will be talking about. So, here the baby is in breech presentation first. Then what is happening is the doctor feels for the baby's head or the bottom. Then the doctor turns the baby around slowly, okay, and the baby will be in the normal position for delivery, normal presentation for delivery. Okay, it has been turned around and they have brought it to cephalic presentation. Clear? Now we will talk more about external cephalic version. See, the external cephalic version success rate is around 50 to 60%. Then anytime it should be attempted before her labor pains. Okay, ideally before 37 weeks of gestational age itself. And then why we are choosing this 37 weeks of gestational age? Why so? Because we have so many reasons for this. Why 37 weeks? Because at this time fetal maturity is attained, right? And then the amniotic fluid volume is reduced much when compared to the earlier gestational age. Then before this time, there can be more chance that the baby can go for a spontaneous rotation. Yes, and then any cause that is leading to a need for immediate delivery is not going to be that much severe also. Okay, not that much severe. Clear? Yes. Now, let's also see what are the repeating. Now, let's also see what are the contraindications. So, contraindications for performing external cephalic version. Placenta previa, when labor has started, when there is oligohydramnios, or there is placenta abruption, there is nuchal cord, there are uterine abnormalities, there is fetal growth restriction or multifetal gestation. So, in all these cases, don't ever think about doing external cephalic version. Clear? Right. Then, when we can say that the chances of external cephalic version can be successful? Okay. We can say when the woman is a multipara or she already had an unengaged presenting part. Yes. Then there is not an anterior placenta or non-anterior placenta, and the woman is not obese. Okay, obesity is not there, and there is abundant amniotic fluid. Okay, abundant amniotic fluid means sufficient amount of amniotic fluid, not polyhydramnios. Okay, so all these things you have to check, and these things are going to increase the chance that external cephalic version becomes successful. Clear? Yes. Then we'll see how to perform this external cephalic version. Okay, so properly if they perform, it should be done in the center. Okay, where there are facilities for fetal delivery is there. Okay, then USG and CTG should be done before starting the procedure to assess the fetal well-being. Sometimes, if the woman needs, epidural can also be given. Sometimes, tocolysis with 0.25 milligram subcutaneous terbutaline that is given 30 minutes before the procedure can be helpful, because this relaxes the uterus as well as it increases the success rates. Yes. Then the patient is asked to lie down left. Okay, and she should take Tredelenburg position after emptying her bladder. Okay, she should be asked to empty her bladder first. And then the breech, if it is disengaged, no problem. Suppose if it is engaged, means you have to disengage the breech slowly. Okay. Then fetal head only is manipulated to the pelvis. Manipulated towards the pelvis. So, while manipulating this, we can adopt either forward pull, repeating. So, while doing this manipulation, we can prefer to adopt forward roll of the fetus, which is easier and a preferred one, and then we can even try a backward flip also. Clear? So, when should you discontinue the procedure? So, procedure is generally discontinued when there is excessive discomfort, or there is abnormal fetal heart rate that persists and there are multiple failed attempts. Okay, so there are multiple failed attempts. Clear? Then you have to know that anti-D immunoglobulin is to be given if this is a RH negative pregnancy. So, this is an indication of giving anti-D immunoglobulin. And remember the fact that once the procedure is completed, you have to confirm the presentation. So, the presentation is confirmed by using ultrasonogram once again. Okay, that the presentation is cephalic now. Clear? So, this is all about external cephalic version. Now, we'll see the mechanism of labor in breech presentation. So, mechanism of labor. See, in a normal cephalic presentation, since the fetal head is going to be the biggest part of the baby, once the fetal head is delivered, the rest of the body will be delivering without any trouble. But here, since it is a breech presentation, we have to consider deliveries at 3 levels. Okay, we have to consider delivery of breech, then delivery of shoulders, then delivery of head. Clear? So, remember, the denominator in breech presentation is sacrum and the engaging diameter in breech presentation is by trochanteric diameter, which is around 9.5 centimeter. So, with respect to the relationship between the sacrum and maternal pelvis, you can have different positions like left sacro-anterior, left sacro-transverse, left sacro-posterior, right sacro-anterior, right sacro-transverse and right sacro-posterior. So, among these positions, right sacro-anterior is the most common position. Clear? So, we will see the delivery of breech first. Okay? So, when we discuss about delivery of breech, you have to know that there is engagement first. Okay? Engagement means we are considering right sacro-anterior position now. So, the engaging diameter, which is the bitrochanteric diameter, is going to engage in the right oblique diameter of the pelvis. Okay? Clear? Okay. Now, what is going to happen is, throughout the breech delivery, there is going to be descent and there is going to be compaction. Compaction means the baby is going to become more compact and compact. Okay, it is going to become more and more flexed. So, there is descent with compaction. So, there is descent as well as what is compaction? There is head flexion and the fetus become more compact. Okay, and after this there is internal rotation, and when this is happening, the anterior buttock is going to come and lie under the pubic symphysis. Okay. After that, there is going to be a lateral flexion. So, when there is lateral flexion, already we know the anterior buttock is under the pubic symphysis. So, this anterior buttock hitches under the pubic symphysis. Then there is lateral flexion of the fetal trunk, and after that, first the posterior buttock is delivered, that will be followed by the anterior one. Clear? So, only thing you have to understand here is after the engaging diameter, descent and compaction is going to occur simultaneously, and after that there is going to be an internal rotation where the anterior buttock comes to lies under the pubic symphysis. Then there is going to be a lateral flexion of the baby. When lateral flexion is happening, the anterior buttock is going to hitch under the pubic symphysis. By this time the posterior buttock is going to be born. After that, this will be followed by the delivery of the anterior buttock. Clear? Yes? That's all. Now, we will see the delivery of the shoulders. So, since after the buttocks are born, we have to deliver the shoulders. Then only we have to deliver the head. Can you imagine? Like it is just opposite to a normal delivery. Clear? Okay. So, delivery of shoulder. So, here the engaging diameter is going to be bis acromial diameter, right? The engaging diameter changes now, right? And then remember, this diameter engages in the same oblique diameter as that of the buttocks. Clear? Now, anterior shoulder, just like the anterior buttocks, anterior shoulder hitches under the pubic symphysis. So, similar way, the posterior shoulder is delivered first, followed by your anterior shoulder. Clear? Yes. Now, after so much has happened, now only there is going to be the starting of the major trouble. How to deliver the fetal head? Because the fetal buttocks or fetal shoulders are having a less engaging diameter when compared to the fetal head, right? So, we will see how we are going to deliver the fetal head and what are the complications we can face, right? Okay. So, delivery of the fetal head. See, in some cases, the engaging diameter becomes suboccipito-frontal diameter, and this engages just opposite to the engagement of the buttocks as well as the shoulders. Okay, it engages opposite to the engaging diameter of buttocks and shoulder. So what happens is the occiput rotates 45 degrees and this hitches under the pubic symphysis. Okay, and after that the head is borne by flexion and the face will be followed by the occiput. Clear? Now, before starting the maneuvers for delivering a fetal head, I want to make you understand that there are two modes of delivery for breech presentation. Okay, so the mode of delivery, if we take, we can either choose elective cesarean section or a vaginal delivery. But remember, there are some indications for doing an elective cesarean section in a case of breech presentation. So, elective cesarean section is done for many reasons. We have reasons like, repeating again, we have reasons like lack of operator experience, or there is a patient request for cesarean section, or there is prior prenatal death or neonatal birth trauma. Okay. Then there is a larger fetus like above 4 kgs, or when there is a preterm breech baby, that is having a weight less than 1.5 kg, then twin with twin pregnancy with first twin in breech presentation. Then there can be severe fetal growth restriction or oligohydramnios, fetal anomaly, in some cases incomplete breech like stargazer breech, Footling breech or knee presentation. Then breech in a previous cesarean section. Then when breech is associated with other complications of pregnancy like pregnancy induced hypertension or placenta previa. Okay. So, all these cases need elective cesarean section, and remember, elective cesarean section is the preferred mode of delivery in breech presentation. And then sometimes primary gravida with breech can also be considered as a relative indication. Clear? Right. Now, while doing vaginal delivery, okay, you have to assess 3 factors. Number 1 is cervical dilatation. Number 2 is what about the membrane status, and number 3 is how is the presenting part, where is the presenting part, at which station. So, ideally when breech delivery is planned, through vaginal route, you have to give 1-to-1 monitoring. Okay. So, 1-to-1 monitoring is ideal because there is increased chance of cord prolapse. Clear? Right. Now, what will be doing in various stages of labor? So, in first stage, we have to do continuous electronic fetal monitoring and auscultation of fetal heart rate should be done every 15 minutes at least. Okay. Then you can offer pain relief for the mother by using nitrous oxide with oxygen, or you can even offer them, repeating, cut this pain relief point. And in the second stage, you have to know that less than 30 minutes will take for second stage of labor in 60% of women, and it will take more than 60 minutes in 20% of women. Clear? Okay. Now, we have to understand that breech labor generally proceeds slowly, but whenever there is a steady cervical progress, then it is considered as a case where there is a adequate pelvic capacity. Okay. So, most of the times, as I told you, cesarean section is preferred instead of induction or augmentation of labor. Clear? Right. Now, there is one scoring system that is called as Zatuchna-Andrews scoring system for breech delivery. Okay. So, here we are going to assess some factors. Okay. So, we are going to assess the PA of the babies. Okay. So, here we are going to take B and S and we are going to consider this PA. Okay. So, PA of the babies are assessed in this Zatuchna-Andrews scoring system. Just know what is being assessed. No need for knowing everything about the scoring system. Okay. So, the factors that are considered in Zatuchna scoring system include parity, gestational age in weeks, estimated fetal weight in kilogram. Okay. So, it is age, estimational fetal weight. Then you have B for breech, previous breech, and then S for station. Clear? So, it is parity, gestational age, estimated fetal weight, then previous history of breech, and then station of the fetal head. Okay. So, these are the factors that are considered for the scoring system. And then remember, suppose if there is a score less than 4, then they are poor candidates. Okay. They are poor candidates for vaginal delivery. That means this becomes another indication for cesarean section. Clear? Yes. Now, we will see how we will be performing vaginal delivery now. Okay. So, what are the things we have to do while this vaginal delivery is being carried out? So, what are the methods of vaginal delivery? See, we can allow for a spontaneous vaginal delivery. We can perform a partial breech extraction, or we can even perform a total breech extraction. Clear? So, what is spontaneous vaginal delivery? So, the term is self-explanatory anyhow. So, the fetus is expelled entirely, okay, without any traction or manipulation. Then we have to talk about the partial breech extraction. Partial breech extraction is nothing but assisted breech delivery. Okay. So, here we are going to allow the baby to deliver spontaneously up to the umbilicus, and after that we will be helping the baby to deliver the rest of the fetal parts. Okay. So, fetus is allowed to deliver up to the umbilicus, and after that assistance is given to deliver the remaining parts of the fetus. Clear? Yes. So, ideally we are having a no touch policy till the buttocks and lower back are delivered. Okay. Even till the umbilical level. Okay. Till the umbilical level there is going to be a no touch policy. That is, you are not going to even touch the baby. Clear? Then after it is born, the baby is wrapped in a clean cloth, and remember, the back of the baby should always be anterior. Okay, so that means the back of the baby should be facing the obstetrician. Okay. Then, if suppose there is any loop of the umbilical cord that is prolapsing out through the gap available, then this should be kept aside to prevent the compression. You have to hold the baby thumb over the sacrum and the fingers are kept over the pelvic girdle. So, can you understand? So, till this what we have done is the baby is delivered till the umbilicus. Then after that we are going to wrap it around a cloth and keeping the back of the fetus in the anterior position itself. That is, we should be seeing the back of the fetus only. Okay. We are going to hold the baby like this. Okay. The thumbs are kept over the sacrum and the fingers are kept over the pelvic girdle. Clear? Right. So, once the body is delivered, and if you are able to see the inferior angle of scapula, you will be hooking out one arm out. Okay, one arm hooked out. Okay, then the first arm is which is delivered. Okay, the first arm, repeating. The first arm is delivered by turning the trunk to either side. The second arm spontaneously falls after this. Clear? So, we are holding and then we will be waiting till the inferior angle of the scapula is seen. Then, if the hand is above, we are trying to hook one arm out and we will be just turning the baby to one side so that one arm will be falling out and the other arm will also be spontaneously coming out. Clear? Right. Now, yes, as I said, now we are going to see the different maneuvers for delivering the fetal head. Okay. So, delivery of the after coming head. So, first technique what we are going to do is Marshall-Burns technique. See, this is done as soon as the occiput is seen under the pubic symphysis. See, you are able to see the occiput here under the pubic symphysis, right? And then you have to give a steady traction, okay? A steady traction is given. Okay, so this is what they are doing. They are giving a steady traction by holding the feet of the baby. Okay, by holding the feet of the baby. Then the third step is baby is swung in an arc over mother's abdomen. Okay, see, if you see here, this is the foot, right? So, holding this foot, first we are giving a steady traction and after that we are just making an arc with the fetal body, okay, and such that the fetal body should be thrown over the maternal abdomen. Clear? So, this is what is being done, okay. Are you able to see? So, from this position, they have made an arc. Clear? Then, what happens is, head will be borne by flexion. So, head is borne by flexion, okay. If needed, in this case, you can even ask for a suprapubic pressure by an assistant. Clear? Right. There is another technique called Branch technique, Brachet technique, repeating. So, there is another technique called Brachet technique. So, in this technique, it is similar to Marshall-Burns technique, except the baby is allowed to hang by itself, okay, we are not giving a traction, and then suprapubic pressure is not applied. Clear? Yes. Next method is USMLE Wyatt technique. So, first let me explain this procedure. After this, we shall recall this maneuver together once, right? So, after the delivery of the rest of the baby till the nape of the neck, what we are going to do is, we are going to support the baby with our left hand, okay. The whole of the baby's body is going to be supported by the left hand, okay, and you will be holding the fingers, that is the index and the middle fingers over the molar eminences of the fetal head, okay, and you will be giving a pressure such that you will be maintaining the flexion of the fetal head, okay, and the right hand should come above and it should be on the fetal head such that the middle finger should be on the cervical spine of the fetal head, and with these both hands you will be giving a downward traction, and just when the nape of the neck is visible, you should ask one of our assistant to give suprapubic traction also, okay. So, that is what seen. So, this is the left hand which is on the molar eminences and this is the right hand which is on the occiput and the middle finger is on the cervical spine, and just when the nape of the neck is visible, you will be asking an assistant to give suprapubic pressure. Clear? After this, just like the other maneuver, the fetus is swung over the maternal abdomen and then the fetus will be born. Clear? So, we will record this maneuver once again. So, first, baby's body is supported by the obstetrician's left forearm. Then, in that index and middle fingers are applied over the malar bone and will be maintaining the flexion of the head, okay, to promote the flexion of the head, right. Then we will be having two fingers of the right hand hooked over the fetal shoulders, okay. So, here you will be hooking two fingers over the fetal shoulders also, okay, hooked over fetal shoulders and the middle finger over the cervical spine. So, when the nape of the neck is visible, we will be giving suprapubic pressure by an assistant. Then fetus is swung over the mother's abdomen and then the head is born. Clear? Right. Now, there is also another method of delivering fetal head, which is forceps delivery. Okay. For that, we will be using a forceps called as Piper's forceps. Okay. So, this has a downward curve. If you see the picture, you will be able to understand. So, this has a curve that will be able to accommodate the fetal body. Okay. So, with this, we will be giving a controlled traction. Okay. We will be giving a controlled traction. And remember, the blade that is placed on the maternal left side, okay, is to be in the operator's left hand, okay, and the same thing on the other side also, okay. So, maternal's right side means it should be held by the maternal operator's right hand, okay. So, other than this, we can even go for a total breech extraction. Okay, so far we have seen assisted breech delivery, then we can even go for total breech extraction. Total breech extraction means we are not allowing any of the spontaneous movements to happen naturally and we are going to extract the baby as it is from the uterus. Clear? And mostly this is performed under general anesthesia. Clear? But however, not only delivery of the head is going to be a complication that we can expect in a breech presentation. There can be some other associated complications also. We shall discuss one by one. Okay. So, complications in breech delivery. First one, there can be extended legs. Okay. So this is a picture which is showing that the baby is having extended legs. What you are going to do is, you are going to move your hand slowly along the thighs and you will be reaching the popliteal fossa. And after reaching the popliteal fossa, you have to move the knees laterally. As the knees are moved laterally, the knees will flex down. Okay, and once it is flexing down, you have to hold the ankle of the baby and you have to pull it down. Clear? Now first one, hands are passed along the thighs up to the popliteal fossa. Then knees are pushed laterally. Then this will flex the knee and bring the ankle down. So the ankles is now held by the hand between the fingers and the legs are pulled down. Okay. See, if you see this maneuver, the baby is grasped by both the hands, right? By both the hands, by femoro-pelvic grip. So that is where the baby is holded, right? Then, if you see the thumbs, they are kept parallel to the vertebral column, right? So thumbs are kept parallel to the vertebral column. Now, you should start this maneuver only when the inferior angle of the scapula is visible. Okay. So, started when inferior angle of scapula is visible, and what they are doing is, you see, they are just lifting the baby and giving a lateral flexion, right? So, baby is lifted slightly to cause lateral flexion, and if you see this picture, the trunk is rotated 180 degrees, okay, so that you will be bringing the back anteriorly, okay. So, back is brought anteriorly, and throughout you have to maintain a downward traction, okay, maintain a downward traction, and then we'll be trying to bring the posterior arm under the pubic arch. Okay, so this is the posterior arm. So as we have rotated, the posterior arm now has come anteriorly and it is under the pubic arch. Okay, then we'll be rotating the trunk again and we'll be trying to bring the back anteriorly. Okay, so what happens is, anterior shoulder is delivered under the pubic arch. Okay, delivered under the pubic arch. Clear? So, I hope you understood this with this picture. First one, this is Lauset's maneuver which is done for extended arms. Okay, see, the baby's arm is here. So, it is done by holding the baby at the femoropelvic grip, and see that your thumb should be parallel to the top of the vertebral column, and you will be giving a lateral flexion, and you have to turn the baby 180 degrees so that the back will be coming anterior, and as the back is coming anterior, the posterior arm will be coming under the pubic arch, and then you will be rotating it again 180 degrees, and that will be bringing the So we shall repeat this maneuver once again. So this is Lausitz maneuver that is performed for extended arms. Okay. So this is a widely practiced method, and what we are going to do is, when there is extended arm of the fetus like this, we'll be holding the baby by a femoropelvic grip with the thumbs that are parallel to the vertebral column, and then the trunk is rotated. The baby is given a lateral flexion twist. Okay, lateral flexion, and the trunk is rotated to 180 degree, so that we will be keeping the back anterior. Okay, and after that you will be maintaining a downward traction throughout, and it will be bringing the posterior arm to the anterior, such that the posterior arm will be coming under the pubic arch. Okay, you are able to see it has come under the pubic arch here. Then the trunk will be rotated in the reverse direction, so that the back is still in the anterior position. So anterior shoulder will be coming again under the pubic arch, and the anterior shoulder will also be delivered. Clear? Now, for bringing a posterior arm, okay, bringing down the posterior arm. Suppose there is a posterior arm, what will be doing? Okay, so this is the second method we have to do. Okay, so we'll be grabbing the fetus by the legs. Okay, fetus grabbed by the legs. Then it will be pulled towards the maternal thighs. Now another hand will be introduced. Okay, so another hand introduced along the posterior arm of the fetus till its elbow. Okay, introduced along the posterior arm of fetus till the elbow. Then arm is gently flexed. Okay, it is gently flexed by gentle pressure at cubital fossa. So just like our Pinard's maneuver, how we delivered extended legs, we are going to deliver the posterior arm also. We are going to tap the cubital fossa. Okay, so then the arm is swept over the face and delivered. Clear? Right. Now we'll see about another complication, that is neutral arms. So neutral arms means arm is flexed at the elbow with the forearm behind the occiput. Okay, so forearm is behind the occiput. So I'll show you the picture, then you will be able to understand. So in this maneuver, what we are going to do is, we have to rotate the fetus in which the direction of the neutral arm is pointing towards. Okay, for example, here this is pointing towards this side. So we'll be turning the baby towards this side. Okay, for example, if it is right neutral arm, we have to rotate the baby in a counterclockwise. Okay, suppose if there is a left neutral arm, then you have to rotate the baby clockwise. Okay, and while you are rotating, what happens? The face will be coming to be in the maternal pelvic side walls. Okay, so after this, what happens? The hand obviously falls down, or otherwise, if it is not falling down, you have to go for gentle traction of the fetal hand. But most of the times, there can be chances of injury to the fetal humerus or clavicle with these procedures. Okay, right. Now we'll see another complication, that is obstructed shoulders. Okay, suppose if there is obstructed shoulders, means what we will do. See, the same thing, you have to give a rotation. Okay, so 180 degree rotation should be given. Okay, so this obstructed shoulder will be brought anteriorly and it will be delivered. So we will be rotating another 180 degree and bring the posterior shoulder anteriorly, and then we will be delivering. Clear? Right. And the last complication is entrapment of the after coming head. Okay. So, this can happen due to incompletely dilated cervix. Okay. So, you can try giving injection terbutaline, which will help in uterine relaxation. You can give terbutaline as a dose of 0.25 milligram subcutaneously. Okay. Or you can give incisions on the cervix, which is known as Duerson's incision. Okay. Duerson's incisions, and these are given at 4 and 8 o'clock positions on the cervix. Remember, you should not give it in the 3 and 9 o'clock positions, because that is where the descending cervical artery is going to supply the cervix, right? And the third option is, if it is extreme, okay, if it is extreme and you are not able to do it any maneuvers, you have to try replacement of the fetus in the uterus, and you have to go for a cesarean section. Okay. So, this is known as Zanavali maneuver. Clear? So, with this, the maneuvers are over, but still I want to discuss with you about the general complications that a breech delivery will have. Okay. So, what are the complications of breech delivery that can be normally expected? Okay. Number one, for the fetus, there is more injury when the fetal head is tried to be delivered. Okay, by either by spontaneously or by maneuvers or by forceps, whatever it is, there is more injury to the fetal head that will be resulting in intracranial hemorrhage. Okay, so if you see, this will also be the most common cause of death in fetus with a breech presentation. Clear? And because of this, suppose if the baby recovers, there can be chances of fetal hypoxia that will be leading to hypoxic ischemic encephalopathy, right? Also, suppose already we have seen there can be injuries to the humerus or clavicle, right? So, all these things should be kept in mind. Okay. So, yeah, with this we are finishing the topic on breech presentation. So, until we meet in the next video, take care, happy learning, and bye-bye.